to the pelvic girdle, the hip. This one kind of drives people nuts. Not you guys, but you'll have me. Okay, I'll guide you. The hip bone. The hip bone is actually made up of two, what we call coxal bones. MUO is made up of. So they're made up of two bones. And this is where people start driving and getting nuts because they can't figure out what that is. I mean, they can figure out what this is when it's all together, but this looks like Legos all over the place. You can't figure out if it's a boat or a car or whatever. Okay. So these are two coxal bones. They're attached anteriorly by something called the pubic symphysis. Right there is the pubic symphysis. So you can see it right here, the blue area. Anteriorly, pubic symphysis. Posteriorly, it attaches to the sacrum. So I'm going to try and do this all together. All right, so you have right and left. They attach anteriorly by the pubic symphysis, which is made up of fibrocartilage just the way your intervertebral discs are, right there. Posteriorly, it's going to attach to the sacrum, which goes like this. Of course, I don't have the right bones. That. Sorry. Does that make sense? Now it looks familiar to you. So just like one of those bakery shows that we see on TV, we put it in a bake, put it in the oven, and voila, you get this. It's all done for you. All right? So that's what is all together. So there's your pubic symphysis. Sacrum is right here, and it's made up, the pelvis is made up of the two coxal bones. Okay? But we're not there yet because the coxal bones are made up of three bones. Okay? So each coxal bone is three fused bones. Okay? You can't see where they are delineated, but I'll show you in the next picture because they're color coded. So we have three bones. The ilium, and be careful of the spelling of this because it's with an I, and there's one L there, but it's with an I. We have an ilium in the small intestines. We'll talk about that in A and P too, but I don't want you to get confused with the two. When you have ileolitis, you better spell it right because it's going to make one's the bone and one is the small intestine, and that makes a big difference. So I just think of I is a part of the hip, right? There's an I in hip, there's an I in ilium. Here, just think of the esophagus as part of the digestive system, so is the ilium in the small intestine. So if you want to use that. You also have the ischium and something called the pubic bone or the pubis, which is the smaller of the three. So what we got here is this, right? One coxal bone, the other coxal bone. There's the sacrum that connects the two coxal bones posteriorly, and the pubic symphysis that connects the coxal bones anteriorly. Now, let's pay attention up here. All right, I'm going to show you. It's not bad. This is the right coxal bone. You're going to see this coming right over here, and that's the right coxal bone. This is where it's helpful to look at an articulated skeleton when you have a bone like this so you get oriented. There's a big gaping cavity over here. This is called the acetabulum. Okay? This is where, when we talk about it, this is where the head of the femur, the head of the thigh bone, goes right into there, the ball and socket joint. It's called the acetabulum. The coxal bone is made up of 3 bones, as I said before. You have a big ilium, which is here in yellow, a smaller ischium, that's in blue, and a very small bone called the pubis, or the pubic bone, that actually attaches to the pubic symphysis. All 3 of them actually interconnect in the acetabulum. You can see it here. I will not be cruel with you and say, what bone is this, be specific, because you can't see these sutures in here. So if I want to know what bone this is, be specific, I'm going to ask you over here. I'm going to ask you over here. I'm going to be way far from the border. Okay? Now, you're looking at the lateral view, just the way I have it here. Now look what's going to happen here. This is where the quest is important. This is anterior. This is posterior. Okay? You see a big hole over here. This is called the obturator foramen. That will always be inferior. It will always be the lower part. Okay? Now look what's happening here. We have a bump over here, a spine. Okay? You have a spine here. If you could visualize it, it's a little bump, but we call it a spine still. And in some pelvic areas, you'll see it more pointy. You also have a pointy one over here, and pointy over here. Okay? Now look at the names, because I bet you can do this. You know this is anterior. This, you see this? This, not this. This is called the anterior superior iliac spine. You could call it the superior anterior iliac spine. I'll give you full credit. But it's called the anterior superior iliac spine. The rest is gravy for you. What is this one called? Go ahead. The what? This is, listen to the name. Anterior superior iliac spine. What is this? Anterior inferior iliac spine. Good. What is this one over here? Not this, this. Posterior superior iliac spine. What is this? Posterior inferior iliac spine. Do you understand why I want you to do well on that quest? All right? If you understand anterior, posterior, superior, inferior, this isn't bad. You've got to orient yourself. But it's not, and if you know one, you'll know the other 3. I don't need to ask you 100 questions. What is this one? What is this one? Because then you'll get both wrong. What's the purpose of that? If you could understand this one, then I know you understand the other 3, unless it was just random. But then you wouldn't pass anyway, because if everything is random, I doubt very much, otherwise you'll be winning the lottery. All right? I don't need to ask 100 questions for you to see if you understand how this is put together, arranged. Does that make sense? That's not too bad. It shouldn't be, okay? All right? You'll also see, let me show you this too, other features. That's the obturator foramen. All right? We have an obturator nerve that goes through there. You'll learn about that later. This here, this little notch over here, this is called the greater sciatic notch. This little one over here, what do you think that's called? The lesser sciatic notch. Okay? Now, we call this the greater sciatic notch because what happens here is this. There's a ligament that comes here where my finger is. And now it looks like a hole. What comes through there is the sciatic nerve. Have you ever heard of anyone having sciatica? That's what that goes through there. And we'll learn about that later. Okay? So that's what goes through there. Okay? Questions so far? All right. Now this is the lateral view of the right coxal bone. Now we're just going to do this. Pay attention up here. What we're going to do is just turn it around and look at the medial side. Boop. That's the medial side. Here's the part that attaches to the sacrum. Here's the anterior superior iliac spine. Here's the anterior inferior iliac spine. You're just looking at it from the inside now. That's still going to be the obturator foramen. You're still going to, well, it's not late, you can't see it, but over here you'll see the greater sciatic notch. Okay? So it's not bad. I think what makes students have nightmares about this is because it just looks irregular. I think if you study it, pay attention to it, spend some time with this, you'll understand where the different parts are. Okay? It's not hard. It's just you got to orient, and that's why I don't think pictures will do its justice with this. There are videos on YouTube, certain doctors and certain anatomy professors and stuff, and they'll take this and they'll go all over the parts. I can't endorse all of them because I haven't looked at all of them. So my suggestion is, yes, look at that, but then make sure your book is open so they're saying the right thing. Because it might not be a doctor, it might not be a professor, it might be a ninth grader going over it and wanting to just post it. So I don't know who's doing that. They'll call themselves, like, I've seen Dr. Fabian. He sounds like he knows what he's talking about, but there could be something that might be wrong in it. I don't know. I haven't looked at all of them. So just use it with a grain of salt. They are good. I think videos are much better than pictures because it becomes a three-dimensional thing when you turn it around. So my suggestion is, yeah, a lot of people will take pictures and then label them. There's certain apps that you can take pictures of, and then you could put labels and stuff. It's difficult with your smartphones. If you have a tablet, I've seen a lot of students doing that and labeling things. They're free apps or something. But when you have it three-dimensional and you turn it around, you can freeze frame them. I think that's more three-dimensional. I think that's more better conducive for your study as opposed to just pictures. Unless, of course, you know what the pictures are. You know what I'm saying? If you're familiar with what they are. All right? And then we use parts as landmarks. We put our fingers over here, and we can feel those areas. You place your finger on the anterior superior iliac spine, you can feel where that is. On top of where the iliac crest begins, you put where that is. This is an area now between your two fingers where there's no blood vessels or nerves. So this is a safe spot that we could actually put an injection in, and we're going to put some medication into the muscle there. So you'll be using these later on. Don't forget about this stuff, okay? Now, a true pelvis versus a false pelvis. This is really referring to pregnancy, okay? You can look over here, and there's this imaginary line called the arcuate line. You see it? The pelvic brim, it's also known as. Okay? See that little line there that's going across here? Okay? Above that is going to be our false pelvis. Below that is the true pelvis. The false pelvis does not dictate if a baby can come through out the pelvic cavity. Because look at how big that false pelvis is. You could put a huge baby there, you could put a lot of feces there, you could put a lot of gas, you could put a big tumor in there. That could hold a lot of different things. That is not going to dictate if a baby can get through there. But below that is the true pelvis, which is narrow. That's going to dictate if a baby can get through the pelvic cavity. Does that make sense? So that's our true pelvis. Think of it like a funnel, where it's very wide and broad up on top, but then it becomes very narrow down below. All right? So the pelvis is below that line. Okay? Questions about true and false pelvis? How can you tell if it's a male or female pelvis? I remember, this is a short story. I remember asking students, this is about like 5 years ago, I asked students, can they tell if this is male or female? And you know, people like, you know, they're guessing and things like that. And one woman said, "Oh, obviously that's a male." And I said, "Well, how did you tell?" She said, "Well, all the ribs are there." Think about it. Adam and Eve took the rib. Took a while. It didn't hit me either. But I bet you half the class here is going to spread that to other people. All right? And it's one of those you have to think about. Anyway, so how can you tell? Okay? The easiest way is where the pubic arch is. Okay? This pubic arch over here. In males, the pubic arch is shaped like a V. You see it there? It's shaped like a V. That's very narrow if a baby's going to come through there. I'm going to show you this way. Right? Very narrow. But look at the female. It's shaped like an upside down U. See it? That's how you're going to tell. Okay? If you look at, what's the best way I could do this? Can you see the pubic arch? One's a U shape and one's a upside down U and upside down V. All right? That's how you're going to tell. A baby can come through that quite easily in a female. Again, my right arm or right hand is the female. It's much wider. Again, keep on saying this. Physiology reflects anatomy. Function reflects structure. Okay? You'll see a lot of that going on. Okay? And in certain females, they have what we call an android pelvis, which is the shape of a male's. It's just that the way it grew is that they have that V over there. And that's, when I feel, you know, when I palpate and I get to measure inside the vagina about with my fingers, it gives me an idea that it's too narrow. We're going to have some problems with a baby coming through there. So we can predict if there's going to be some issues that she'll probably need to go for a C-section. Okay? So again, over here, this will be female and this will be male because of the way the pubic arch is. Okay? Questions on that? All right, and hip replacement, you don't have to go through all that stuff. Okay? Now, lower limb, pretty easy on this. One bone, two bones, many bones. We've seen this. If you know the upper extremity, lower extremity is going to be a piece of cake. Okay? We're going to throw in a couple other things. For instance, we're going to throw in a patella, a kneecap. And instead of 8 carpals that we saw, we have 7 tarsals. Okay? Here's the femur. Okay? The head of the femur is up there. We have a greater trochanter, a lesser trochanter, 2 areas that are pretty easy to see. Down here, not so that it's confusing, but it's very similar to the humerus. This is the right one. We have a lateral epicondyle and a medial epicondyle, just the way we saw with the humerus. It's on the outer aspects of the distal end of the femur. Then we're going to have 2 condyles. These are the epicondyles. More medial or more inner is going to be the condyles. We have a lateral condyle and a medial condyle. It's better seen if we flip it around and see the posterior aspect. Now, this is medial and this is lateral because it's the same leg. This is the right leg. So there's going to be our medial epicondyle, our lateral epicondyle. This is going to be our medial condyle and our lateral condyle. And in between, we have a little notch there called the intercondylar notch. It's a notch in between the condyles. All right, so let me show you. This is the anterior view of the right femur. Medial epicondyle, lateral epicondyle. Lateral condyle, medial condyle. Let's show you, if this is how it is on me, let's turn it around so that you're seeing the back of the right femur, the posterior side. Here's medial, here's lateral. Medial epicondyle, I'll go around like this so you can see it. Medial epicondyle, medial condyle. Intercondylar notch, lateral condyle, lateral epicondyle. Okay? Not bad. Just follow. If you, again, that quest is so vital for you to know. Otherwise, if you're lost on lateral and medial, you'll be lost on all this. If you're lost on anterior and posterior, you'll be lost on this. If you're lost on proximal and distal, you'll be lost on the bones. You've got to have that under your belt. Yep.
Is it okay to just be lost in general? Like, I know that there are actually terms, but like...
What do you mean?
We're gonna go deeper.
No, that's it. In terms of what, the bones?
Yeah.
That's it.
That's it?
What? There isn't much more.
So we're just gonna...
It's basically, it shouldn't be hard. It should just be the volume that you're getting in such a short time.
Okay. Yeah.
And I'm going to show you how to, do something on the board. I'll show you how to go about taking on this.
So we're not just doing it today.
No, we're going to do it all today. We're almost done. Yeah, I'll show you. Let me finish up here. Okay? Any more questions about the femur? It's just the volume. That's what kills everybody. That's why you got to go to the learning center or go to open labs. That's the kind of stuff. That's where, because you can't do everything. That's what makes A&P lab different than any other lab. Is because when you leave here, it's not like you just hand in, let's say, an assignment or just hand in a lab exercise and then you go home and forget it for like a week. Here, you got, it's like another class. So there's a lot of studying with this. Yeah. All right, so there's the femur. Here's the fibula and tibia. Okay? Two bones. And the patella that's on the top, but that's an easy one. Okay? It's just the kneecap. Now, we have the tibia and fibula. This is weird. I've never written any, today, I haven't written anything at all today, right? Odd. I'm not even drawing, I'm just writing. But this is just an FYI. We have a tibia and we have a fibula. The fibula is on the lateral aspect, and it's the little one, just the way we say a little fib. It's the thinner one, okay? There is no such thing as a fibia or a tibula. And I say that, I still get at least 2 or 3 students in every class still doing that. And because of that, I can't even give you half credit, because I don't know which one you mean. Do you see what I'm saying? It's too close. So I'm just letting this out with you now so that you don't make that same mistake. I'm trying to have one class not do that. And I've done this for about 7, 8 years. And every class, someone does it. So let's make this class not be the first, or be the first one where I could not do that. All right, so just be careful with that. All right, it's a minor thing, but it's a big thing. You fractured your fibia. Do you see how spelling counts? Okay. All right, so there's a couple things on here I'll just show you. There isn't much about the fibula, but the tibia is this. Okay. Oh, there's one thing I'll show you. This is the right tibia. And you see how down below on the distal end, one comes a little bit longer than the other side? Okay? That's called the medial malleolus. And you could feel that bump on your own ankle. That bump on the medial side is the medial malleolus. And it's on the tibia. You could also feel a big bump on the lateral aspect of your ankle. That's the lateral malleolus, but it's not on here. It's on the fibula. It sits like this, if this is the right side. So the lateral malleolus is on the fibula. The Medial malleolus is on the tibia. See, I'm saying tibia. Tibia. It's getting late. All right? Does that make sense? Okay? And you can feel those. That's what's going to help you to determine if this is right or left. And when you have it in your hand, you'll feel it. There's a big, I can't really explain it. You'll have to feel it. You'll see what I'm talking about. There's a pointy end. If I was going to do a cross section of the fibula, of the tibia, all right, it's kind of doing this kind of motion. This is the posterior aspect. This is the anterior aspect. And it's making this triangle where it's flatter over here, but it's pointy up here. When it's in your hand, you'll feel it. And then if you know that the pointy end is going to be anterior, and I see where the medial malleolus is, I can tell you that this is going to be the right tibia. Does that make sense? You got to pick something anterior, something that's posterior. You got to pick something that's medial or something that's left. Not and, just or, and then you can figure out if it's right or left. Okay? And then the feet. The feet are pretty easy. All right? Over here in the ankle, we have tarsals, not carpals in the wrist, but tarsals in the ankle. And instead of 8 carpals, we have 7 tarsals. Now, I do want you to know 2 names of them, though. Okay? And I'll tell you why. The biggest one is this one, and it's called the calcaneus. That's the most commonly fractured bone in the, at least in the tarsals. So you should know that one. That's the ball of, or not the heel. You also need to know the uppermost one, the one that's up here, and that's called the talus. The talus is part of the tarsals. That's the one that's going to articulate with the tibia. So that's why you need to know that one. Okay? So you're going to have tarsals here, 7. And you need to know the talus and the calcaneus. Then you have the metatarsals. 5 of those. And then you're going to have the phalanges. And very similar to what you had in the fingers. So there's phalanges in the hand and phalanges in the foot. You have 3 phalanges in each toe, except for the great toe. You have 2 phalanges there. And again, the way they label it, the great toe is digit 1. The little toe that went wee all the way home, okay, that's number 5. There's 3 in each. Again, proximal, middle, and distal phalanx. Except in the great toe, you only have a distal and proximal phalanx. Same way. Okay? This is a side view. Here's all the tarsals. Again, there's the talus that I want you to know, the top uppermost one. And this is the calcaneus, the heel one, most commonly fractured one. Because that's what you land on, the ball of your heel. Not ball. Is that the ball of your heel? No. That's the ball, right? And this is the heel? I don't know. Well, it's the posterior one, all right? I got to use the medical terms. All right, the posterior one, okay? Then you're going to have the metatarsals here, and then the phalanges here. Notice that there's an arch here, the way they're doing it. That arch is important when you walk. It kind of does the same way like our back that I explained to you. It gives that cushiony kind of thing. Well, it kind of does this cushiony thing here too, with your feet. So that when you go for long walks, you have that little cushion, that little springing that goes on. And certain people, they don't have this arch, and these tarsals are actually much lower, and there's no arch there. That's flat feet. So you can imagine if you walk long distances with flat feet, you're going bam, bam, bam. That's why it hurts, because there's no cushion there. So they have to have special soles in their shoes to try and create that arch, so that it can have that springing. Okay? So let's talk about articulations. We could do it by mobility, how well they can move. They might not move at all, just fuse together. These are called synarthroses. These are immovable, like the skull bones, the sutures that are located in your skull bones. Then we have amphiarthroses, and these are slightly movable. A good example of this is your intervertebral joints, like our skeleton here. One vertebra and a second vertebra. You got that disc in there, which is made up of what? What kind of cartilage? Ooh, you did some study, right? Fibrocartilage, right? But when you have two bones like that on a vertebrae, they don't move that much. They might only move like this. That's it, very little. But when you put a bunch of bones together, that's what's making it look like you're moving a lot. But when you put only one-to-one joint, it's only moving very little. Does that make sense? It's when you put a bunch of them together, that's what's making it look like you have a very flexible back. But they don't move that much when you just deal with just one joint. But mostly in our body, we have very freely movable joints, and they're called synovial joints, also known as diarthroses. These are your shoulder joints, your hip joints, your finger joints. All right, these are mostly what's in your body, but we do have the other ones also. And this is just showing you can do this on your own, but these are showing you, like, here's the synarthroses. These are the examples that we have, and then we have subtypes of these, like a gomphosis. Is basically where your tooth goes into your jaw. That's immovable. The only way to remove it is for them to, pull it straight out with some kind of metal instrument, right? So that's what those are. Okay, and then here's a couple of amphiarthroses, and the diarthroses really go into synovial. Now the diarthroses, there's a lot of examples, and they're pretty easy to manage because you do these all the time when you're walking or running or throwing a ball or whichever. So the best way I could explain where we're going to start off with is this. Pencil and paper. All right? Now, this is a bone and that's a bone. So we have the paper and the pencil as bones. Where they touch is an articulation. Okay? That's our starting point right now. Now we could do different things. We could have this glide like this, where the pencil stays perpendicular and it's just gliding on the paper itself. That's called a gliding joint. Okay? And we usually see that where the clavicle meets with the sternum or chest plate. It kind of glides over that. Okay? We also have, if we put this back up here, we could take this pencil and leave the articulation there, but we could bend the pencil. So the pencil becomes angular. Does that make sense? Okay? So this is angular, and this is more like your elbow, your knee joint, right? It's got a little angle that's going on there. Still, yeah, you can't move it in all directions, but that's a big range of motion that you're doing over there. So it's synovial. Then we have a cousin to it called a saddle joint. A saddle joint is kind of shaped like this, where it's going to, like a person's going to go over a saddle, putting legs over the saddle, like, okay? And this is what's happening with that. All right, a good example is our thumb doing that, the opposable thumb, touching that thumb to that pinky. Okay? We can also take this and do some circumduction, where it just goes like this. So the point of the pencil and the papers don't move, but the pencil is going to go around like this. That's our ball and socket joint that we see with our hip. Also rotator cuff, like what we're doing with our shoulder. Okay? So we have the ball and socket that happens over here. And we also have a cousin to it called the ellipsoid, which doesn't give you that much range motion that you got on your shoulder. But it's the socket portion is not so deep. When you compare it to the one I just showed you, it's much deeper. You put a whole ball in there. Does that make sense? So they're similar to each other. So they kind of put them in the same situation. Okay? And then you got rotational, which is basically the pencil and the paper are touching, but then you're just turning this. Does that make sense? And that's a good example is simply shaking your head no. Okay? And that's what's happening with that. We also have a little bit happening in our forearm too. Alright? Now this is what I think you should do. You basically have this thing, and you basically have a few things. You could break it up into 1, 2, 3, 4. So there's only 4 sections to do. Pick out one day and you say, I want to do the skull. I want to know everything about the skull. Spend 3 hours and do everything about the skull. Look at all parts of the skull. Look at all the videos. Look at all your pictures. Look at the skull and do that. Don't worry about everything else. You'll give yourself an ulcer. All right? Just for one day, just do that. Okay? And maybe your partner, he or she can do the vertebrae and the rib cage. That's about equal. Okay? Know all the different vertebrae and know how you can tell the difference between one and the other. The ribs, have the difference between false and true ribs. Do all that. Take 3 hours over here, have your partner do 3 hours over here, and I guarantee you teach it to each other. Without the book open. You teach the skull to him, he teaches the vertebrae to her. Without the book open, I guarantee if you teach it, you will know it. I guarantee it. And then give yourself a quiz by labeling all those different things for yourself. Get masking tape and go over there and just label, not label it, but put like numbers on there on a sheet of paper what each number is. All right? Then for you to review it, you go and now you don't have to spend 3 hours on this because your buddy just trained it to you. So maybe you have to spend like an hour and a half. And the next day, you could do the arm and your buddy does the leg. And do that. And teach it to each other. I guarantee if you teach it, you'll know it.